I've done quite a lot of work in management regulation policy work, but I'm really speaking to you as wearing my clinical hat today. I'm a consultant physician who's worked for 26 years in the north of England. I've done general acute medicine and geriatric medicine. My particular focus is on the medical care of older people. And about 3 years ago, I took the pretty major step of leaving the hospital and going to work for a PCT. Of course, I've now been chucked out of the PCT because of transforming community services, but that was the idea. And given the stage and my years, I didn't split my job. I thought I needed to focus and to really see if by developing more expertise in community services for older people, it could have any impact on quality. And of course, what the PCT hoped was that this was going to reduce demand, and it's a moot point as to whether it actually did. So I just wanted to ask, first of all, to think about hospitals and what do we think secondary care is for? Because I think we sort of rather gloss over this in a way. We sort of think we assume we know what it's for. And I think it's a source of expertise. You've got highly trained specialists who live in hospitals on the whole. We have inpatient beds for acutely ill people. We do procedures. We do highly specialist investigations using big pieces of kit. Traditionally, outpatients, of course, have been tagged on to a hospital. The ambulatory care is usually done in the same place, has efficiency gains in terms of your staffing, but it doesn't have to be that way. Rehabilitation is carried out within hospitals, and of course training for future healthcare staff. But what's it actually used for? And I think it's all the preceding things, but as well, it's about crisis management, it's a place of asylum, it's a safety net, it's the place of last resort. If everything else breaks down, you know, social circumstances, all sorts of issues, the hospital is open 24 hours a day, 365 days a year, and that's where people end up. And I can tell you story after story, and they may be appropriate or not appropriate, but that's where they are. It's a holding place, so people, when they get in, are held, as Candace said, and it's a place of reassurance for patients, relatives, at least something's been done, a crisis has been addressed. So I think we have to be aware of this, in a way, softer stuff as to, you know, why our services are there. I'm going to really focus on the care of older people because I think this is the real driver for admissions. We don't need to go into detail of all this, the slides are there, and I thank the National Clinical Director for Older People, David Oliver, who's sort of put together all the stats in a nice set of slides which he managed to share with me, and I've used the data there. But I think this tells us that we've got a changing demography. Clearly here, and that life expectancy is now much greater than it was. At the start of the NHS, 48% of people died before they were 65, whereas now it's less than 18%. I mean, that's phenomenal, isn't it? That's just and of course that's because children died of infectious diseases, mothers died in maternity, and then the toll of things like coronary artery disease with, you know, where we're much better now at treating people. We continue to live longer, but in fact we also have a tale of the old now, that the survival graph is moving. So people are surviving longer and then they sort of drop off towards the end rather than an attrition in middle age. Which is not to downplay, you know, illness in middle age, but this is the demographic change. BMJ said the number of oldest old is going to double, and these are people who have complex illnesses and the need for joined up integrated services. I think this is a success story. It's not a problem. You know, the tsunami, the rising tide. I mean, these apocalyptic phrases we use. Let's not do that. Let's celebrate this. You know, people in this room, I hope, are looking forward to a healthy older age. You know, I hope I'll be here in 20 years' time. And it's down to a whole lot of social initiatives, better public health, a small amount of better curative medical treatment, undoubtedly, better management of chronic conditions, and a better potential for people to flourish. So that's my first marker, really, that this is not a terrible problem. I think it poses challenges for us of how we best deal with this, but it's otherwise we're sort of wishing all these people away, and that's not a good position to be in. The question is, are older people living longer, but are they actually more dependent? I mean, that's the real issue. And in fact, there isn't any evidence of that. But because the population is growing, the numbers, the absolute numbers of people who have a dependency will be greater. So it isn't that sort of, oh, all these old people are living and they're all, you know, sort of terribly disabled and dependent and what a terrible existence. But your actual absolute numbers are going up. And we know about long-term conditions, that already 40% of people over 65 have 2 long-term conditions, 16% have 3+, and this is only going to rise. So again, this is the background of our population. In terms of what happens in hospitals, 60% of admissions, 70% of bed days, delayed transfers, emergency readmissions, deaths are in the over 65s. And 40% of bed days are in people over the age of 80. And I think Candace's slide also showed that. So you've got a hospital case mix in England where 75% of the bed days are in people with 1+ long-term conditions. You've got a percentage of people who are malnourished, they're incontinent, step-down services are important, and 2/3 of people in receipt of home care services have been in hospital. So this is showing us that there's this great interdependency with social care, community care. The question is, are we actually managing this well? And I think Ken Rockwood from Canada put this very well and said, if we design services for people with one thing wrong at once, and people with many things wrong at once turn up, and then we say they're the wrong patients and then they're inappropriate, maybe there's something about the way we're delivering services which is not right. And the other thing is, if you get it right for these very complex older people, you'll get it right for the whole population, because you'll have slick, efficient services. Dementia is another issue, huge issue in terms of hospital inpatients. If you took a snapshot of 220 beds, 96 people would have depression, 102 would have dementia, and 66 would have delirium. This is sort of has been, you know, these are about averages. There may be a combination of dementia and delirium. So, are there any possible solutions for how we're going to deal with this? I think there's something about facing up to, this is the real issue of the day. This is the real problem. So I think we have to define your problem first, in detail, in a thoughtful way. And then I would say you never deny older people the facilities of a general hospital if they need them. But you should be using the facilities for care which is very complex, which needs specialised intervention in an episodic way. And so there have been initiatives, as Candace has referred to, better long-term care management, better integrated care between primary and secondary care and social care, the right resource in the right part of the system at the right time, focus on prevention, and I put self-management in there. And the question is, does that make any difference? And does better community care work to reduce demand? And as Candace again has said, there is limited evidence. Some evidence is stronger. We recently did a review at the college of the literature, and these were our headline messages that practitioners with special interests in the communities, GPs, providing outpatient services, there was really no evidence of more cost-effective services, less referrals, better clinical effectiveness. Specialist outreach clinics are certainly clinically effective, but there's no evidence of cost effectiveness. Telemedicine at the moment, and when I put this slide together, I would say there's limited evidence, and but a lot of the evidence is 8 or 10 years old. And of course technology has moved on, and I think we're going to hear more about that. And I personally think this is an area which may very well hopefully have better evidence coming through. Intermediate care, post-acute, better functionality for patients, it's actually the same cost. Hospital at home, clinically effective, no cost savings, but patient satisfaction is very high with services that are provided closer to home. So there is an advantage, it's just that it's not maybe going to solve some of our financial problems of the NHS at the moment. So are there options that we should think about? And I have some personal experience of trying to work with these. Community matrons, we all got given community matrons a number of years ago, teams of nurses to do case management. Unfortunately, the evaluation showed no benefit, but the schemes have been running much longer now, and maybe there's more to be got out of that. I think predictive risk modelling, where you try and pick out people who may be in danger of having a hospital admission, using PAR tools, PAR 2 and the subsequent son of PAR, and we are awaiting some real evaluation of that, and again that may very well be a helpful thing. Specialist nurses in the community, better management of long-term conditions, more self-management, expert patients, patient peer review groups, etc. Better liaison between specialist consultants and the primary care team. Ambulatory care located in the community, is that going to save us any money if we move out patients from the hospital into GP surgeries or polyclinics, health centres? Investigations and procedures in the community, patients would like it. Is it going to save us any money? I don't know. We do need to think about the variation in general practice and upskilling of general practitioners about acute illness, about having the confidence to manage acute illness in the community without sending people into hospital. Better out-of-hours care, as Candice said, we need to understand the impact of that. End-of-life care planning. Are people, I mean, we know that most people actually die in hospital. Is that their preferred place of death? Or can it be better managed? So I think there's a huge, there have been big programs about trying to get better end-of-life care, and particularly looking at care homes, that whether people who become ill in a care home may be approaching end of life and yet they get bundled up into an ambulance and sent off. Better management of long-term conditions in care homes, advanced care planning and training of care home staff. I personally was involved in a project trying to get that in place. It's very hard work. The constant, the turnover of care home staff, and just trying to get a sort of a change of culture, I think. When we've got healthcare assistants, they're not medically trained, who get very scared if somebody appears to be ill and they don't have the confidence. So I think there's a big issue, and putting in Liverpool Care Pathway Gold Standards framework, it's worth doing, but it's hard. And then of course there are the wider public health issues about how we're managing obesity, alcohol, etc. Another option, which isn't quite reducing your demand of the hospital, but is better managing at the front end, and there is some evidence here that if you have a really good front door assessment of older people and you have an OT, physio, social worker, all your team there at the front door, then you might be able to do a very rapid assessment and then post people out to a re-ablement scheme, a virtual ward, hospital at home, rapid access, clinic, supported care at home, etc. So that's something which we could think about, I think, in terms of what happens. And better discharge planning from hospital will reduce your length of stay. And again, I think this is often ignored in terms of managing beds and demand management. We think it's all about the front end and it's about the pull of the back end. Issues there, of course, about reduced funding at the moment in social care and how we organise that. So my own experience, how did it feel to go into the PCT to try and work on this? I wrote a care home strategy with a whole group of people from, across long-term condition management, community matrons, district nurses, social care, end-of-life care, etc. And we came up with quite a lot of recommendations about how we might help to manage the care home sector better. The question is implementation, and I have a feeling it's actually sitting there in the PCT office and, nothing actually really happened. I gave some clinical leadership of community matrons, which I think was helpful. I ran a lot of community clinics. There were problems of IT. There are all sorts of firewalls across the community. Your system doesn't talk to the hospital system back and forth. I had a terrible problem of getting access to clinical notes because the hospital held on to them and said I couldn't look at them even though I'm a consultant physician, because they couldn't go, operational issues here about notes, and we're not all on the electronic patient record. And even if we were, are we going to be able to allow different localities to talk to each other about the notes? Yeah, I'm nearly there. There were operational difficulties about being a pioneer, I think, trying to do things differently. I was doing a lot of domiciliary visits, closer working with GPs. Did it make a difference? Well, there's still a relentless rise in admissions. And I think it needs a whole system approach with a proper pathway involving community services, acute hospitals, GPs, social services, specialist physicians. And that's a big job, and it's not easy. And I tried to do bits of it, but it didn't really, I was not able to enable a whole system approach. I think you've absolutely got to go through the whole system and get everybody signed up and say, this is what we're going to try and do. Finally, I just wanted to finish with a case study because this is a very typical issue of something that may happen on an acute admission. Somebody who's elderly, living alone, needing some social care, has a daughter, being mildly forgetful, heart failure, type 2 diabetes, osteoarthritis, takes a lot of medication. A carer comes in one morning, uses the key safe to get the key, finds Mrs. Smith in her chair in her night clothes. Has she been to bed? Has she got up? She's much more confused. She can't move out of the chair. And what's to be done? So the question is, what does she need? It's not where should she go, but what does she need? She needs a medical diagnosis. Why is she immobile and confused? She needs a medication review. She needs a functional assessment. She needs some rehabilitation to restore function. She needs a further social assessment to see whether or not that's going to be suitable. Is the daughter coping, etc. So my question is, how will those things best be done? We've got an acute situation, need for urgency. Is it better done in the community? Is it better done in the hospital? And it seems to me that that's the way we need to think about these things, about what is the need and how do we deliver it. Finally, I think we need to be really careful about the language we use. I think aiming to reduce hospital admissions, all these old people going into hospital, potentially it's ageist. If you or I suddenly got sick, collapsed, were not able to move, we would be taken to the hospital. And we would expect to be so. And I think we need to be really careful that we're not denying older people the access to expertise, investigations and care. But I think we need to redesign hospitals to do the job needed. I think many of the things we do in hospitals can be done elsewhere, but we need more evaluation and research. And I think at the moment, emphasis on reducing length of stay may pay more immediate dividends. Thank you.